And then we'll start with some introductions. Renee, would you just mind introducing yourself one more time for us?
Yeah, my name is Renee Bolio-Banks. I'm the Eldrin resident at NACC. I've been here a little over 5 years, and I'm from the Leech Lake Nation, Miigwech.
Miigwech. And Nikki?
Hi, I'm Nikki Jardina. I'm a nurse at NACC and been here off and on since 2017, and I work with Lindsay on this ECHO project.
And I'm Lindsay King-Cooney. I'm the harm reduction specialist and coordinator. I also facilitate Midwest Tribal ECHO with Nikki and Dr. Robbie, who isn't able to join us today, but she's our medical officer and our family practice physician. So that is our ECHO team. I'll move on to some announcements. I'm going to share my screen. All right, so welcome everybody. This is the Midwest Tribal ECHO. We're the Opioid Use Disorder Education and Treatment Series. Today we are fortunate to welcome Whitney Dickson, who will be talking to us about the Cass Lake IHS harm reduction program. A little bit about NACC if you're not familiar. So we are an FQHC that was established in 2003. We're located in South Minneapolis in the heart of the urban indigenous community right on Franklin Avenue. We provide a full spectrum of services, primary care, MLUD. We have a dosing clinic, a dental clinic, behavioral health, intensive outpatient treatment, lots of harm reduction services and traditional healing services as well. Our website is listed at the bottom in bold, so feel free to visit us if you have questions. We like to list the positions that are currently open at NACC, which looks like there's quite a few. So feel free to, again, go onto our website under the jobs tab, and you can read about any of these open positions. Some session guidelines. Of course, please know protected health information. We love to see your faces. So if you're willing and able to turn your camera on, that is amazing. And then if you could just let me know who you are in the chat. So your name, title, organization, and email, and any other information that you would like to provide, that would be great. And I can send out information on today's session and the post-evaluation survey. Some announcements. So upcoming ECHOs, our next ECHO will be September 4th. It's CFS and underserved communities, and then to be determined for September 18th. This is a list of other ECHOs that cover similar topics to us. So feel free to let me know if you'd like any more information on any of those other programs. We do offer continuing education credit for those who are eligible. We just ask that you fill out the post-evaluation survey to receive the credit. And so I'll put that link into the chat today, and then I'll also email that out to everyone as well. And then finally, case presentations. So my email address is listed at the bottom of this slide. If anyone has a case presentation that they would like to present on a future ECHO, feel free to let me know. They make for great discussion. And I think that's it for me. So I'm going to stop sharing and I will hand it over to Whitney. Welcome.
Worked in the practice, so I'll see if I do this right. Oh, like, okay. Okay. So thanks for the welcome and thanks for having me here today. And I'm just was asked to come and talk a little about our harm reduction program here at Cass Lake IHS and how we kind of got started and the background behind the program. So these are the learning objectives, but I'm not going to read through them. A little bit about Cass Lake. So we're located in northern Minnesota. We have outpatient ambulatory care clinic with multiple providers. We serve about 12,000 patients here. And then within the pharmacy, we also provide medications for the 4 area tribal clinics. And then at IHS itself, we have 24/7 emergency department, a walk-in clinic, and kind of all the wraparound services right here within IHS. So kind of going backwards and looking at how like we saw this need for having local harm reduction services. And basically for myself, I've been working here about 7 years. And when I was treating patients for hepatitis C as one of the main things that I do, I noticed that over time there was kind of a shift in patients were identifying injection drug use as their risk factor for acquiring hepatitis C. So kind of in the beginning, you can see if I look at all of the patients, about 78% identified injection drug use as a risk factor. And then as we move forward, and I'm kind of just looking back at those last 50 patients, we are seeing younger patients and like healthier otherwise, other than they have hepatitis C, but the common denominator is injection drug use. So as I was providing the treatment, kind of looking and thinking, okay, what are we doing to prevent new infections and kind of get to hepatitis C elimination? So being a little bit more proactive than just reactive and coming in after the fact. So I actually attended the White Earth Harm Reduction Summit back in, I think, 2018. And that's kind of what got me thinking about it and figuring out how we could do it here. I was a little delayed with COVID, so it took a while to actually get up and going, but that was kind of the background of why I felt like there was a need for something to be done here. So kind of, I just started out with looking at what was available in the area. Maybe there was something where we didn't need our own program here. This is from the NACC website at the time when we were getting started. There wasn't really anything when I was doing the research that was close to us, right there in the middle of the Leech Lake Reservation. So, and we'd heard from patients that it was really hard to purchase syringes. They're getting a lot of pushback if they went to a retail pharmacy nearby. Since in Minnesota, it was up to the individual pharmacist to decide if they wanted to sell those syringes. So what we were hearing from patients was that it wasn't easy, or there was a lot of stigma involved with trying to request those. And again, there were some limitations on how those pharmacies could offer or advertise, or they could not advertise for having those syringes available. So that was kind of looking at that there was that need or a gap in coverage within our area. So the other part of it was I kind of always was looking, and we wanted to have it so it wasn't just a needle exchange, but what other services could we offer within the pharmacy, because pharmacy is accessible. People can walk in, you don't need appointments. We're here throughout the day, people know where to find us. So kind of thinking about what other services we could provide within the pharmacy. And one thing that I noticed was we had a lot of ER visits for STI testing. So kind of thinking of how else we could have quick and easy access to testing outside of the ER. And on top of that, when patients were going, we have a lot of locum providers. So people would maybe get chlamydia and gonorrhea testing, or they would get hepatitis C, but not necessarily getting that whole panel that if they're at risk for one, they're probably at risk for more than one STI. So again, trying to make it a little bit more streamlined of what we were ordering and make it simpler for patients. Also, I do like contact investigation with the state for syphilis. I work with their DIS, so we're noticing basically a link or an association between our syphilis cases and injection drug use. So again, how can we bring the groups together or bring those people in for more care? And then that summer before we started, we were seeing an increase in ER overdose visits. So figuring out how to get more naloxone out into the community and into the hands of the right people that needed it. And then people that were going, or patients that were going to the ER to access these services, the majority weren't impaneled with primary care. So it's not like they were going to the ER and their primary care provider, they weren't really seeking care anywhere else. So those are kind of things that we looked at and kind of decided that these could all be put into our program to develop the harm reduction program within the pharmacy. So trying to get started, this part was kind of different pieces that had to go together. I had meetings with the tribe to kind of work together to see which gaps we could fill, like what could we do, because we're here at IHS, but they could go out into community where we might not be able to do that. Also meeting with the tribal police department to talk about the plan to have the program and let them know, and also have that opportunity to ask questions, because when you talk about harm reduction, especially syringes or needle exchange, people kind of have sometimes people have questions about it, or maybe myths that they've heard. So just being able to answer those questions and get that worked out before we started was important. Also making sure that the pharmacy leadership and staff in here were on board, since it was going to be in placed in the pharmacy and all the pharmacists take part in the visits, making sure everybody felt comfortable with that, which I did a staff survey and kind of gauged people's interest. And most people, everybody said yes, but most people just wanted to know more and learn more before we started, so that again, they could feel comfortable with the program. And then presenting to medical staff, I did that so that we could, the med staff and the nursing staff was on board, and everybody kind of again had that baseline understanding. And so I think it did it did well in making sure that people didn't have these preconceived notions of what this program would look like or what the syringe program is. And so we didn't have a lot of pushback, luckily. And for us, we decided to just do word of mouth for a while because we didn't know how it was going to work, or if that we needed to change things as we went going. So we just did word of mouth and then one Facebook post after about 3 months. So pretty much everything has just been spread by patients or clients that are coming into the program. And then the next part was educating for myself as a pharmacist or other maybe healthcare providers. I feel like we want to know everything about whatever we're working in or talking about. So kind of twofold again, making sure we were gathering resources and education for patients. So mental health resources that are local to us, as well as substance use if somebody is interested in a program, and then patient education materials. So kind of gathering all the things that we thought would be relevant or people might ask about. And we definitely added along the way when people would ask a question and we'd be like, oh, that's a good idea. We should have a resource available for that. One thing that comes to mind is like food resources, because that came up. So putting together things where they could find that in the community. So we're changing things as we went along. And then for pharmacy staff, giving that background information and some of the data behind what we were given, because there is evidence to support like the programs that we're doing, so that people understood the why. There's the patient, but also again, infectious disease, decreasing that, and hepatitis C. So I tried to make sure that everybody kind of felt comfortable with what we were going to be doing. And then the next part of getting started was our supplies. And for me, this was kind of a little bit difficult trying to just, there's a lot of lists out there. And if you go into some of the places, it's like pages and pages of things you could do for harm reduction programs that are bigger and greater than ours. But for us, we just needed to figure out what we could give that was the essentials and that we could have available in the pharmacy. So I listed some resources there of what helped in terms of looking at different options. And I think most importantly, talking to other programs that are already in place, because they've kind of worked through some of those hiccups already. So creating that, and for me also as a federal facility, figuring out how to pay for the syringes was also the part that was part of getting started, or like that slowed down getting started. So our actual program here, Cass Lake, we have, like I said, it's in the pharmacy. We have syringe services, sharps containers or disposal. We don't take the syringes back within the pharmacy, but we have these 2 red mailboxes basically that we have outside of the facility that patients can just bring their sharps containers to. And I always let people know that that's where we direct anybody who has the sharps to put, like if it's a patient with diabetes or somebody who's using testosterone injections, like whatever it is, it's going to go in the sharps container. So it's not, somebody doesn't know what you're using that for. But people have been bringing them back and we've been using them more. We have the nasal naloxone, our STI testing, condoms, and then, like I mentioned, those different education materials as well. So to come to the visits for us, it doesn't go into their chart. So nothing that we're doing related to the harm reduction visit itself or syringe services goes into their medical record. When they come for the first time, they can come to the pharmacy window, ask to talk to the pharmacist. We also train our pharmacy students to do it as well. But they get an intake form that they can answer some basic questions. It's voluntary. So if they don't want to answer all of the questions, they don't have to. And it kind of just gives us a guide to maybe start a conversation. Like there's questions if they would like to talk to somebody about Suboxone, or would they like to do STI testing, or when was the last time, so that maybe we can glance at it and have again a conversation starter, and if there's something maybe we need to add into the program based on somebody's use. So we do that and we give them a participant ID number. So when they come back the next time, they can just give us their ID number. People can also give us their name, but a lot of patients remember their ID number so that when they come to the technician at the window, they can just say their number and ask for the pharmacist, and it's worked pretty well. The only thing we do put in their chart is if they get naloxone or the STI testing, because we have to enter the orders, but we don't put anywhere in there about the rest of the harm reduction visit. And then, like I mentioned before, all of the pharmacists take part in it, depending on where they're stationed for the day. They provide the education on the materials and those resources. And then when they come back, like I mentioned, most patients kind of know what they want and what they don't want. And I'll show you a picture on the next slide how we kind of organized our materials to make it a little simpler for the pharmacist, but also for the participants. And then we do track the visits internally, just in a log that's only here. So we at least know how many participants we have, how many visits, and what we're distributing, just super basic, like a tally mark of what we've been giving out. So we know what we've been providing. This is just to show you that it's nothing like really grand. It's very small. There's more storage space outside of here, but we have a shelf set up. So when patients come in, the pharmacists check that logbook that I was mentioning to see if there's any notes. Sometimes we'll place a note there for internal communication to say, like, see Whitney when the patient arrives. Maybe the last time they were here, they were tested for an STI, and they need treatment. So we'll just make a little note to see me. So they'll check that binder, see if there's any note on that person, and then come and grab the supplies. Some of the things we decided to kind of package together, like the saline and tourniquets, alcohol swabs. We have condoms and lubricant and things in another package. So trying to make it grab and go, but also not everything in one big bag in case patients don't want it, to reduce that waste. And then a couple different types of sharps containers. We have these needle clippers that everybody loved, but we can't get them anymore. So if anybody has a way to get those, I would be happy to hear about it. And then this is just to give you an idea of what the space looks like. They can come to our pharmacy window. And then in the counseling rooms, it's a closed counseling room that we go in to have the visit, which I think is kind of nice because that's the same room that we do vaccinations or patient counseling on a medication. So when patients, and then they leave with the same pharmacy bag that all the rest of the medications are dispensed in. So nobody really knows what they're going in for. It's not a room that's marked harm reduction, which I think works well. And I just wanted to share this part because when we started initially, we had a program with the tribe where they were able to go out into the communities, but with funding and changes in staffing, they haven't been able to do that, but they created these kind of to-go boxes that they can stock the supplies and at each of the tribal clinics, and then patients can come in and request, and then they'll just periodically go in there and restock so that the services can be available outside of IHS and outside of Cass Lake. And then recently the tribe added a community wellness recovery navigator program, which I think has been great. So basically they'll be there to help somebody at any stage if they want to get to treatment, if they need an assessment, if they just need a peer to talk to, which I think has been a great addition for the tribe to add in the last few months. So kind of looking back at our patient demographics, we started almost 2 years ago. I think we're actually now up to about 140 participants. And then the median age is about 36, but you can see that it's a wide range. So it's not just one age group. We have anywhere from 21 to 68. And then kind of like what I noted at the beginning, a large portion, so about 70% of the patients are not impaneled with any primary care provider. So they're not really seeking care outside of the program. They're not going to primary care providers. So when I last did the numbers, we had close to 500 visits, gave out about 24,000 syringes, 365 boxes of naloxone, and 1,200 condoms. And we've continued to give more, but I just haven't had a chance to update the slides recently. And then looking at what I was talking about earlier about the pharmacy STI standing order. So we have a standing order in place where the pharmacist can order this whole panel for testing. if a patient presents and would like to have the testing done, we'll place the orders. And then if a positive result comes back, we also have a standing order to provide treatment. If it's something that requires an injection, like the Bicillin for syphilis, then we'll coordinate with the nurse team that's just across the hallway to complete the treatment. So they can kind of do everything within the pharmacy visits rather than having to be referred out to same day or primary care to get that taken care of. So when I started, I kind of mentioned earlier that my grand vision was that, oh, we're going to have this testing and everybody will come and want it because it's so easy, but it didn't happen. So in the first 7 months, we only did about 6 patients, or 8 times people wanted to do the STI testing, so it wasn't very popular, even though it was available in here for them to do. And we did find some positives, which was a good thing. So Hep C, syphilis cases, and some of those participants did already know about their Hep C, but some of them were new to us. Like maybe they were tested positive while they were incarcerated, but they just never got treated. And at that time, we had about 35 participants. So again, it didn't quite go as I planned, but about 5 months, 6 months after we got started, we had this opportunity from headquarters to receive $10 incentive gift cards and the way we kind of decided to implement them was $10 for doing the STI testing within the pharmacy if they hadn't had any testing in the last 3 months, just because we were also trying to think about resources and lab resources when we were coming up with the timeline for the testing. And then we also added an additional card when they come back for their results or complete treatment if there's something that they need to pick up, like a doxycycline prescription. Because before this, we had a lot of trouble finding patients to come back for the results. So this has helped to bring people back. It might not be in a couple of days, but sometimes it's a few weeks or a month later they show up because they remember they could get that $10 card, and then we can provide the treatment. Since a lot of the patients we're working with might not have stable housing or a current phone, it makes it a little bit more difficult to reach them. So this kind of worked to have people return. We didn't do any advertising, and we still had a lot of people. We had people waiting in the lobby when we got started, and we have never done any advertising for this, and we still have plenty of people wanting to do it. And they don't have to be part of harm reduction. It can be anybody who is eligible for care here that comes to the pharmacy. So this is in the first 6 months of the program. When we started, we gave out close to 200 incentive cards, and we did 101 of those STI bundles. So a lot more than we initially did in those first 7 months without the incentives. About 33 were not part of the harm reduction program. And then out of those 101 tests, we had 44 different positive tests from 40 different patients. So some people with multiple positives. And you can kind of see the spectrum of we had a little bit of everything from syphilis, Hep C, chlamydia, gonorrhea, pregnancy. And the majority were part of the harm reduction program that had the positives, but not everybody. So for me, if it's something that's an opportunity for you to have within a harm reduction program, it seems like a great place to implement or add these services, because it's patients that were probably not seeking care outside. At least I didn't gather data, but when I would go to order the tests, most people hadn't had any testing in REHR, at least for a couple of years or ever. So I think it's something that's brought people in and also just started the conversation about STI testing and made them realize it's easier, because people sometimes now come back, even if they're not due for another card, they'll just request to have the testing done. So ways that we kind of worked on to help reach patients that might not always be the easiest to reach. And I think having to figure out how to come at it from multiple ways, because one size doesn't fit all. We can't just call every patient if you don't have a phone, or we can't go to their house or mail a letter if that might change. So trying to be creative in ways that we reach patients that might have a positive result. One way that we did was with Tribal DIS, we created a consult. So I can place a consult if I've tried the ways that I can reach them through IHS, which is basically a phone call or a letter. And so placing that consult to the tribe, they can go out and try to find the patient, they'll bring them in, or they brought out doses of medication to the patient directly if the patient can't come back. So that worked well in locating patients. And again, they can use different means of communication that we aren't able to. So that has helped. And then another way, we have created a follow-up flag, which basically it's just a pop-up in our chart. And if anybody knows IHS, EHR, it's a little bit older. And so this is like there's probably something fancier, but for us, it's just a little box that pops up when you open their chart. It's a last resort. So we've kind of tried the consult, we've tried the phone calls, nothing has worked, but the patient needs treatment. So now they'll have a pop-up when they come in. I don't write positive for syphilis so everybody sees it, but I'll just put something vague in there with a note to look at a specific date that I wrote a note in their chart with what they need. And this has worked. Maybe a patient goes to the ER outside of hours, and that ER provider sees that notification and can act on it. Like, oh, this person needs labs and a bicillin dose, or they just need ceftriaxone. And so that's something we've done as well. It's a little bit cumbersome because it has to be monitored by myself and like put it in and out by one pharmacist. It's nothing automatic. And then again, communication that we use internally. So we have that binder that I was mentioning that we check every time before we go to the visit. And then our Script Pro is our pharmacy communication system, or sorry, filling system. So we can put something on there that just says like, see Whitney, or ask patient to go to lab. And it's only within the pharmacy that we can see it. And maybe again, the patient got a med from the dental clinic that might not use our regular EHR, but they come through the pharmacy for the med. So another way to help try to find patients that might not always be the easiest to locate. And then just some things that I think all work together, again, trying to think of different angles to approach it, is policies that are standing orders that we have in place. So we have a partner treatment policy, so to do expedited partner therapy. So if we're talking to the person and they let us know that, I tell them they're positive and they say they have 3 more partners, we can, of course, ideally bring that patient in and do testing and treatment. But in the last resort, we can send the expedited therapy, partner therapy home. And something that says that we can treat non-eligible partners, because that sometimes would come up if that was possible here at IHS, but it is. And then the naloxone standing order, we also have standing orders for first responders, we can provide it. And then in the last year, we implemented lab express testing, so patients can go directly to the lab without seeing any sort of provider, no nurse or anything, and just request the express testing, and there'll be a standing order there for them to complete. So basically, we're just trying to make it so no matter where a patient presents, there's no wrong door. Like, they'll be able to request STI testing no matter where they are in the facility without being bounced somewhere else. And then with that express testing, again, I follow up on those positives and do the same thing in terms of treatment and talking about partners. And then vaccination standing orders, because if we're ordering, we can offer any vaccines, or if we do the hepatitis B serologies, we can offer that vaccine as a follow-up if they aren't protected from that. So some ways that over the last almost 2 years now that we've kind of used to grow the program, going out and doing community engagement, so visiting some of the local homeless shelters, the opioid treatment program, powwows, events that are in the community, health fairs. And I think that's also got the word out there, since we don't have a lot out there in writing about the program. Just talking about the program, letting people know, like, I always feel like, of course, people know that this is going on, but sometimes you'll meet somebody that maybe could benefit and they've never heard, or even somebody that works here and didn't know that this exists just within our own building. So kind of being a little bit of annoying and telling people about what you're doing. And then again, asking about other programs or services in the area. So I try to learn if somebody's asking me about an assessment, like trying to figure out what the process is for it and who the right people are to call, so that I can actually tell the patients what that involves or how to do it, rather than just say like, oh, here's a flyer, here's the handout. So kind of just learning again about all the resources. A lot of times the tribe has a lot of great programs, but I didn't always know about them before I tried to figure out what other things that we could offer to patients. So a few things for us that work well, and both of these lists could probably be added or changed, but I think some things that work well is we have consistent hours and a consistent location, so people know where to find us. A lot of times things are mobile or they move around, and which is great because you find people that might themselves not be mobile, but at least in this case, people know where we're at. We also have all of the pharmacists or the students trained on to do the visits. So we have, I think actually now we have about 13 or 14 pharmacists. So we're all trained to do it. So we always have somebody available that they won't be turned away. We have that private space so other people aren't aware what they're coming in for. We have the lab right here because I know sometimes if you might be off site, you might have to figure out a different way to do testing, but we have the lab right next door to the pharmacy. And I think it's great that we can test for STIs or Hep C and then treat within the pharmacy. So again, limiting that need to make an appointment or a follow-up, we can just do that. And I try, since I'm doing most of the treatments for both of them, well, all for Hep C, try to just be available when patients need me. So they don't have to make an appointment. They just can come in and ask. And as long as I'm not doing something like this, then I'll just leave and go and visit them whenever they come in. So trying not to stick to like a rigid schedule that they have to come into. That might happen if they were referred to an outside bigger institution to receive treatment where they won't be able to be late or those type of things. And then we do have the same day clinic and ER here on site. So if something came up during the visit, we have an easy place to refer patients to if they needed more care or maybe wound care or something like that, that is out of our scope. Some things that could be better, kind of the same with multiple staff, it might be a disadvantage because sometimes I feel like maybe if there was 2 or 3 of us doing the visits, we would establish a better relationship or rapport with the patient because they would get used to seeing the same face rather than maybe a different person each time they come. So that also could be a negative. And then trying to figure out how to engage more with patients. Like I don't expect every visit to be super long and people, asking all these questions but at times like figuring out if there's a way to be more engaging than we are. And I think we try to do that, like I'll make appointments for patients if they need it that are unrelated or kind of help them get to another service, but how we could do better. And then the fentanyl and xylazine test strips, we actually just they're sitting behind me and all the stuff you can see. I just haven't got them out to the program yet. And then trying to get more input from people with lived experience, because right now this is just something kind of we developed. We've taken feedback from patients as they've come throughout the year and changed the things a bit, but not with the overall, like the initial planning. If there's a way to offer rapid testing so that people could maybe come back within the same day or wait rather than days later, because some of our labs take a while to come back. And I just can't say anything about Hep C without talking about those barriers for Hep C medications with Medicaid. So if those could be removed, like the prior auth, and make things simpler to just test and treat would be a huge thing. And then there's always additional supplies and things that we could grow and add. So just trying to learn about that and see what we could do. And then we do have PrEP and DoxyPEP, but maybe trying to be better about universally offering it or having that conversation more often. Right now, it's mostly people who have requested it or specifically wanting that. So trying to figure out how to do better at just starting that conversation with patients. So some of the takeaways that I have, I guess, it's okay to start small. When I was getting going, I felt like, if anybody knows pharmacists, we're a little type A. So I felt like I needed to have everything be perfect and have it all like lined up and I had to know everything about it, but it's okay to just start small and kind of learn as you're going. And I've found that when we've added something, it actually is a good opportunity to have another conversation with maybe participants that have been coming here for 6 months and they kind of know the drill. But now we can be like, oh, we got this new thing. Can I tell you about it and why it's beneficial? And even with like pharmacists providing that education on something new has actually been a good thing whenever we've added something new in there. Trying to be flexible, like I said, with Hep C, I used to have appointments and now I'll make an appointment if somebody wants it, but there's not a requirement to have an appointment. And then if we could have different forms of communication, as IHS is a federal facility, we are very limited on how we can communicate. So if there was updates in that, such as texting or maybe social media, things that we could communicate in a different way would be really helpful. And then you don't have to be an expert. Like I mentioned, the people that you're working with are really the experts. They know what they want and what they don't want. You might be there to provide some additional education they might not know about, but they know a lot more than I do. And so kind of learning from them as well. And then just to remember that we're always learning, and it's not once you get started, you can't change. We can change as you're going and learn from that. 2 like small future goals is a potential vending machine, not in place of the program, because I think having people is still really helpful, and again, having conversations and additional services, but maybe in addition to like after hours or something, or in places that we're not able to get to, and potentially rapid testing out in the community outside of IHS. And then these are just some of the resources that I used with developing the program here. And any questions? Sorry, I'm trying to. I don't know if people have questions or happy to take any.
Thanks, Whitney. Yeah, I don't see any specific questions in the chat, but feel free to unmute or raise your hand if you have any questions or comments for Whitney. I have a question. I just saw one of your slides talked about community engagement, and I was just wondering like what the overall attitude or when you started the program, like the general population, or like what kind of, did you get any pushback, or were a lot of people receptive to it? I guess I would also ask too, with your staff, like just training your staff on harm reduction, like how that went.
Yeah, I think that I was pleasantly surprised that there wasn't a lot of pushback. Like we did the medical staff presentation with an involved nursing and pharmacists, and really everybody saw the need for it and saw that benefit. And pharmacy staff, again, they were pretty on board, other than just wanting to learn more about it before we just started doing it. And I've done quite a few events out in the community, like health fairs and things like that, and I really haven't had anybody say too much negative. It's kind of like, oh, we needed that, or oh, I'm going to tell somebody about this because that's something. And we always did focus too, like whenever I'm talking about it, on the harm reduction portion of it, like not only the syringes, so explaining all the other things that we can provide, and hopefully those, like showing data from us, like these are the patients here with Hep C, and this is not like outside data that I'm using, it's actually our patients, I think helps. So of course you're going to get 1 or 2, but I think the overall feeling was okay. And even with the police department, once they ask some of those questions that are pretty standard that people think of with harm reduction, they're like, okay, well, we need to start somewhere. We should have probably been doing something a while ago. So I would think we were lucky and that people saw that benefit.
That's great, thank you. And we do have some questions and comments in the chat. So Julie said, thank you for this information. It's great. What is the best way to refer folks to you?
You can just tell them to come to Cass Lake IHS, ask them to go to the pharmacy. They can go straight to the pharmacy window and then just say they need either ask to talk to a pharmacist or that they want to sign up for the harm reduction program, and then we can help them. They don't need any official referral though. And we're open 8 to 6 Monday through Friday.
Oh.
Great. And then Jean said, I always pick up on something new every time I hear you speak. Thank you as always for the awesome work.
Thank
And Jose said, does participation in your harm reduction program offer any legal protections, paraphernalia charges?
No, we give them that participant card that kind of says they're a harm reduction participant and the thing that maybe potentially they could show law enforcement, but we don't tell them that they won't be charged or there's, anything like that. I wish that we could do that.
And then Callie said, I love how you said there is room for change and that it doesn't have to be perfect.
Hard for me to learn at first that you wanted it all to be perfect, but it doesn't have to be.
And you said you did just get for the first time a shipment of fentanyl and xylazine test strips?
Yeah, we just got them. I was just kind of figuring out what to put in them for education. So
I was gonna say, yeah, we could send you some resources on that.
Yeah, that would be great.
Okay, yeah, we'll do.
And then I was even trying to sort out again, like how many to put in a bag, like just little logistics that you're trying to. And right now I package them separately because we just want to see like our patients asking for both or one, and if it's both, then maybe we'll package them together in the future. But for now, we were putting them separate.
Yeah, I know here at NACC, we usually pass out 3 at a time. And
That's what
typically people will want both we have like harm reduction menus at our exchange events, so they'll kind of check the box, but usually they'll check both boxes. We have them separated out, but
Okay.
it's pretty rare that folks just want like one or the other.
Okay.
They want both, but we still kind of separate them out. That's just, yeah, what we've been doing.
Oh, Jean's question is good.
Oh, yeah, let's see. Couple more comments. Okay, so you got the address there in the chat. Jean asked, are you able to prescribe medications for patients through a collaborative agreement or on your own?
Yeah, we have the collaborative practice agreement or standing order in place for all of those treatments for the STIs and doxy PEP and then HIV PrEP. So that was all like added within the last year. I kind of just keep going to the med staff and saying, can we add this? Can we add this? So we can do all of this.
Great. Does anybody have any other final thoughts or questions for Whitney? And Whitney, would it be okay to share your slides from today's presentation? Okay, great.
Oh, there's one more question, I think.
Oh, let's see.
Did you have to create a policy?
Oh, one more question, Whitney. Did you have to create a policy for the test strips?
I didn't, but I guess that didn't cross my mind. So I'll look into that.
Sometimes the policy follows the activity.
Yeah, I did see some things with logs and things about it, but I haven't really got that far yet. But I'll look into if I need to do that.
That's kind of reassuring. I work for Fond du Lac, and I feel like we're kind of in the same boat right now where we have funds we're starting our harm reduction work, and it's like everyone will bring up like, oh, is there a policy for that? Like, so I'm just trying to see like if there's a standard like policy that everyone uses for this, and if like it can be shared, because I don't want to recreate a wheel.
Yeah, I know there's some like on the IHS website that I think the Hope Committee has created that you could look at. There's a little bit more detailed, like a log of who you gave each one of those to, and I don't know if that's an actual requirement or if they just, but I know I've seen them on there. And then our others for like the program is pretty just vague, like kind of what we're gonna offer, and how people can get here. Like you don't need a referral, that it's this, we have something that we made, but it didn't include the fentanyl test strips or the xylazine since we just got them. But you can always email me if you have questions as well, and I don't mind like answering or helping.
Amazing. Well, thank you so much for all the work that you've done. It's pretty amazing. And yeah, we just appreciate you and thanks for joining us today. Thank you, everybody. And I'll make sure to send along this Whitney slides and any other information. Feel free to email me if anyone has any questions. Thank you.
Thank you.
Have a good day.
Bye.
Bye-bye.